Welcome back. Here with the Clint Cloud.
Yep, I'm back. I know everyone's. I expect numbers to be low on the last cast just because I wasn't there.
It's not.
I know it was really good. Mad props to my guy over here, Ron. But behind the scenes, everyone, in the silence of the berating that goes on between the two of us, it obviously doesn't change whenever we're off camera. It's just worse than it is on camera. Probably
It's just worse.
He gives me a hard time because I don't really do any of this video stuff, although I do offer all the time. However, the production, the quality from the first time to the next time, I've told you off air, but I gotta get props from the peeps. Props to you, my man.
I accept.
Looks way better.
I accept your compliment, but as you would, I only see my faults.
Yeah.
I only accept the faults. And we were just talking about having lost a whole camera's worth of footage on the last one. And I could have launched that camera into the pasture. I was so mad.
Don't doubt it. We've talked a lot over the last week about just production in general, trying to work on a website, video, all the learning curves that go through that.
Every time that website thing comes up, I've spun my wheels on it, you've spun your wheels on it, Aaron has spun her wheels on it, and then we were looking at potentially having a developer do it.
Yep.
And then just did a quick survey of pricing, and it's it could be $2,000 to $5,000. I was like, that's low priority.
Oh, we haven't talked about price yet. Is that what you were getting quoted? Was 2 to 5?
It wasn't a direct quote. It was just internet guesstimations.
Jeez Louise.
So I was like, you know what? Actually, I think we're just going to focus on our social media presence right now and content creation, and we'll come back to that.
Or
later.
If there's a listener out there who has a lot of skill in this area and you want to be part of the full code team, we recruit you.
Yeah. Anyone want an unpaid internship position?
Yeah, but just to the listeners out there, right? I mean, the quality in our audio and the editing from when we started to that, we knew that as we got this, we wanted to put the content out there. We wanted to talk about the medicine, but the production side of things was going to grow as we grew, and the audio and production got way better. And this is only the third cast with video, and it's already gotten better. So, bear with us. Things will continue to improve and get better as we go. So it's not like...
Well, I had a funny conversation with Aaron the other day, because you constantly worry when you're doing this, and this, we've changed how we do this so many times.
Almost every time we do it, something is new.
And there's stuff that you lose money on.
Yeah.
And you're like, well, there's a part of you that's like, oh man, I wish I never had spent that money. But on the flip side, you're like, I had to do something to learn what it takes, right? And there's plenty of other ways to do that. That's why I keep all this equipment regardless, is because if a setup changes, then you have it, right?
Yeah.
But you just have to do it to learn it.
Yeah.
And there's gonna be some waste, there's gonna be some spillover, but
we share a chat GPT for medicine and the podcast and stuff, and the amount of things that you've chat GPT'd for the setup. And so even with those types of resources, the fact that you can't just get a straight answer of how you should do things.
Yeah.
I mean,
I've told some people about the ridiculous text prompts that I've thrown in just where I'm like, talk to me like I'm an idiot and do it one step at a time, because you run into these errors, and it's a lot of the stuff, AV by and large, right, is intuitive. You point a camera, you turn it on. You put a mic, you turn it on. There's a lot of intermediary steps to make those things look and sound good, and that's fine. But when you move over to the software side of things, it's one thing to do the audio. That's pretty intuitive. But when you go into using quote unquote professional video editing, none of it's intuitive.
Yeah.
You're not going to walk into that and be like, oh, I'll just figure it out. None of it's intuitive, to the point where I put these prompts in and I'm like, you keep saying this word. What does that mean? I don't understand what you mean when you say that, But there's a lot. I make you wear the big headphones so everyone know you're the little spoon.
Fair.
I was going to ask you if you wanted a pair of monitors.
Nah.
He's like, no, let's stick to this. So I prepared zero news for this. It's been super crazy. Last night's the first night I only had one child keeping me up. Yeah. But I'm thrilled. I have all the energy in the world.
You got a solid primed. 5 hours.
Dude, I am primed. So much so I forgot to set my alarm. I passed out and I woke up just at 5. I was supposed to wake up 15 minutes ago.
I often say to my wife, and I've mentioned to other people, but particularly Leah, I'm just like one of the few benefits of me waking up so early every morning is I'll never be late for anything.
Yeah.
Because, I mean, when does anything professionally start before 6 a.m.? Really before 7 a.m.
Yeah.
I mean, I could have slept in, made a 4-course breakfast and showered and everything and like still be early. That's the only benefit from waking up so early.
Well, I laugh because like, and I think you'll know back when I had one kid, right? You could probably call me at 6 a.m. and I'd be like, hey, yeah, I'm getting it. And now if you call me at 6 a.m., I'm like, yeah, what's up?
Yeah.
We've been cooking since 4.
6:15 this morning. You know, it's funny. Now, conversely, my brother-in-law, they stay up a little later. He wakes up a little bit later, probably more so like normal people hours, you know, but he knows if he texts me after like 8:30, I'm not responding. I may be awake, but I've got my phone on do not disturb or something.
I don't even bother.
You know, but then conversely, I'll respond to his text at 4:45 a.m.
Yeah.
And I know that he has his phone on do not disturb, but like our text conversations will often follow that pattern.
You don't hit him with a rise and grind at 4:45 a.m.
I mean, I do let him know that I'm better than him.
Yeah, no. There's just something like I'm at this stage, and I don't know if it's 2 kid stuff. I know you were doing this before 2 kids, but for me, I don't know if it's 2 kid stuff, but like I usually start rousing at like 4, like in the 4 hour, especially if Aaron and I both have to work, like, cause we got to, do kids and stuff, but it's like 4 is a pretty routine time. For
it's
us
just
now.
I'm too worn out by the end of the day. Once you've exercised, worked, done kids, done activities, food, clean up, all the things that are entailed in everyday life with kids and being a working parent and trying to do things like this and stuff. Right. But like, I'd much rather just go to bed and I'm my best at the 4:30 to,
that's peak.
2 p.m.
That's peak cloud.
Is peak cloud. Yeah. Like after last night we were getting dinner cleaned up and stuff. It was, I don't know, 6:30.
Oh, what a dream. Go on.
And Leah was like, why am I so tired? And I'm like, because we've been up since 4 o'clock. Yeah. We've already been up for 14 hours and neither of us have really sat down the whole time. Most people are awake for 16 hours. Like that's almost the whole day. And she's like, I'm like, yeah.
No, it's funny. That hour, that like 8:30 time is like my golden carrot.
Yeah.
Where if I'm like, if I could just get that carrot, it would change my life. Like if I could get those kids to sleep before 8:30.
Yeah.
Like, but they're like night owls.
Yeah. Our kids are early to bed, but me and Leah always have been too. So that's just kind of been the status quo. Although we talked about my youngest, she's kind of extending out her bedtime, which is still not late, but we're getting less of our own quiet time at the night as she extends her bedtime. But anyways, we digress.
You just watch that cup pour out slowly.
Literally had that conversation last night. We're like, I mean, I know it's got to happen, but man, wish we could just keep that rolling because that gives us a little bit more us time.
Yeah, it's like when you have it's like the one kid fallacy when you think your life is super hard and then you upgrade and you're like, I had it made.
I've said it to
life was so good.
So many people, and I'm not hating on the single kid families out there and people who have more than 2, you're probably going to just laugh in our faces and be like, you have no idea. But 0 to 1 kid for us, I felt like was obviously a huge adjustment, but so much easier. The 1 to 2 for us was where it was just like, oh my God.
That's when you just get thrown into the meat grinder.
Yeah. So,
and it just, every month you're like, oh yeah, things will get better.
It's something new. It's always something.
It's always something new. Yeah.
So what are we hitting them with today, my man?
We're going to talk about pulmonary embolism, but one thing I was going to mention, we have official intel on the CCAPP, Clint's biggest point of contention. And anxiety and stress. I laughed. I told somebody about this the other day when you were talking to me about the test and what you're going to do. And you like looked at me and you're like, are you not even going to study? And I was like, Clint, I have the test bank. I've taken the test bank already. And you're like, that's not enough. That's clearly not enough. Are you out of your mind?
Yeah. It's just, I don't love it about myself. I don't, it's something I wish I could change.
We're all flawed creatures. It's okay. It gives you that little flair, that little sparkle.
Is that what I appreciate that, big guy. Thank you. I don't know. It's just how I've been since pre-PA school. And I wish it's something I could change about myself. I want to take the exam. I want to have the credentials. Then when I find out when the exam is, and what is entailed in that, then all the anxiety just floods into the body. And then I'm like, I'm
not going to tell you
inadequate and underprepared and everything.
I'm not going to tell you when I take it. If I pass, I'm just going to leave a copy of it on your desk.
You won't. I won't. If we both take it, no one will know because you don't find out your results until December.
Are you serious?
Did you not read that?
No, I don't read everything.
Yeah, no, I read everything. You don't find out your results till December.
That's ridiculous.
When I took the CAQ, the Certificate of Added Qualification, it's an additional board exam in the PA realm for hospital medicine. I took it in March, early March. And I didn't get my results until the end of May.
That's awful.
Yeah.
That is awful. Anyway, so yeah, that'll be what's dominating our lives for the next couple months.
Yeah. So if I decide to take it, keep them guessing.
You always keep them guessing. If I fail, I'll just say that I never took it.
Maybe that's just what I'll say. Yeah. We'll just see.
All right, so we want to talk about pulmonary embolisms. Let me rephrase that. Clint wanted to talk about pulmonary embolisms. You've been lecturing on this all week. 3, 4, 5 times this week. You've done 5 different lectures.
I've given 3 lectures this week, all in one block. Okay, not multiple times. At my alma mater, my PA school that I went to, and it was acute respiratory failure, ARDS, and then I gave a lecture on pulmonary embolism.
I was distracted by the fact that I can feel this window behind me heating up.
Oh yeah, back feeling
feels
it.
like there's a nice little heater on.
I was gonna say maybe it's just like a heated seat. No. Your traps are glistening.
More like I'm sitting in front of a radiator.
If you start just like beads just coming up on the forehead, then I'll know that we're.
Well, I was laughing. So when we did that last podcast setup, right? I think I've told some people this, but I personally bungled the time like completely. I thought we were shooting at like 5
you told me
6,
about this,
and it wasn't. It was like 1:00, and I had to go to Best buy some stuff for the video and cables and this and that, and I'm like down there and my downstairs luckily is fairly cold because it's underground.
I loved, by the way, how you had your big screen on in the background and
with
the full code logo.
Yeah,
dude, that's like that's the prequel to us ending up with a neon sign someday because all the cool podcasts have their own like neon sign, you know. But that was cool.
You know the guy who does I don't know how to frame this in a nice way. There's a gentleman on the Instagram who does ads for his sign company, but it's always like really controversial stuff. Oh, you know what I'm talking about?
No, I don't.
I'll have to send you one later. Some people will know exactly what I'm talking about.
But,
okay. I was downstairs, but I'm like sweating. You know, it's hot during the day, so I'm dragging stuff in from outside.
Oh, yeah.
And I'm trying to like get things because I've never done all these cameras and stuff, you know, because that was a 3-camera production. At least that's what it started as. And I'm like down there sweating and I'm like trying to get done. And all of a sudden Erin texts me and she's like, Becca's here. And I was like, what? What?
Everything's like strewn about. Not even.
So then they're like, they come down there and I'm just sweat dripping off my face, trying to get everything set up and in the right place and the cameras and the angles and the chargers and the. So then I sat down.
And again, to your credit though, you're the only guy who knows how to set this all up. I mean, I can help with the setup, especially the cameras and stuff. And so even if they wanted to, there's nothing they can do.
No,
you've got to do it all.
Well, and it's like because I'm doing this new, it's an image that's in my head, right, with the stuff that I've collected. So I'm like looking back and forth, and like, you know how to set the audio up. You know how to do that. I could throw all that stuff to you, but like the video stuff is even new to me. So to me to try and explain it would be, wouldn't work very well.
Hear that? He said, I do know how to set up the audio. He does. So he's admitting that I know something.
Yeah, you know how to edit audio in your own way. It's not as good, but
moving on.
All right, pulmonary embolisms.
Yeah,
I think we want to talk about this one because this isn't a brain buster.
No.
Like this isn't a heavy, even like from an advanced AP. I know you have some RV death spiral nonsense to talk about, but but I think one of the points of hitting this is I get asked all the time. I'm sure you get asked all the time, like, why isn't this person going for a thrombectomy? Why didn't they give TNK or TPA, right? And it's like, it is kind of nuanced, right?
It is very nuanced.
But I think if you just kind of get a general handle on what drives the kind of overall mortality risk of this, you'll get it pretty easily, get a better understanding.
And I, of course, to a cohort of PA students who aren't working in the critical care realm, I'm trying to give them what they need to know as far as baseline knowledge on PE. And honestly, I think that, stable PE, which is not what we'll be talking about, but is very straightforward. It's not rocket science. You find out that they've got whatever size clot burden, but they're hemodynamically stable. They don't have evidence of elevated cardiac biomarkers. They don't need ICU admission. They may not need hospital admission at all.
Right.
You start them on oral anticoagulation. You discharge them home. You try and ascertain whether it was a provoked or unprovoked incident, and pending, how you delineate that, plus or minus a hypercoagulable workup or referral to a vascular specialist. But stable PE, standard PE is very simple and straightforward. The more nuanced approach becomes whenever you get into your intermediate high risk, your high risk. They've got these elevated cardiac biomarkers. They've got some evidence of RV strain. Are they hemodynamically unstable? And then, to your point, delineating thrombolysis, IV anticoagulation, interventional radiology, and even still is the critical. I don't know if you have a definitive answer. I think it's very institution dependent, right? But what capabilities do you have at your institution? Do you have interventional radiology? Is someone there 24/7? What's their comfortability in performing the procedure, especially depending on what kind of anticoagulation you have the patient on? So I don't even think that in this cast I'll be able to give a clear and cut answer to when to thrombectomize, when to TPA, right? I can just give what we would do at our local institution, and it's probably what you would do in most larger centers. But
well, in your mind, right, you want to create, it's kind of like that, almost that heuristic type thinking where you're like, how do I boil this down into a 1 or a 0?
Yeah.
And it's like, when you're talking about systemic TPA, right, you're talking about, generally speaking, you're talking about profound shock state,
right?
Like immediately, or
exactly,
impending cardiac arrest, or has had a cardiac arrest, and then we're just like, all right, well, that's that, right?
Yep. I'm sorry, I'm interrupting you. I just wanted to say that I just realized I messed up my verbiage or vernacular. I said thrombectomize. I mean, theoretically, this is an embolectomy. I liked
it. I personally liked it.
The emboli, but this is an embolus, right? You don't end up with a PE from a regional local thrombus that forms like you can to cause a CVA or a CAD and a coronary thrombus and stuff like that, and acute coronary ischemia. So it is a embolus, so it's an embolectomy. Yeah. Just before I get berated.
Well, tomato, potato.
Well, I've said things wrong before, and
I didn't say anything.
You try and you talk about it for a whole month.
Somebody did. Actually,
was it on the last cast?
No.
Oh, okay.
I actually had a conversation with Kyle yesterday, and he brought up the levotoracid.
We keep saying it. It's gonna be a shirt.
It's gonna haunt me for the rest of my days. No, I want you to call next time you do. Like, you have to call IR for the consult. Let's be like, I'm calling to see if you can thrombectomize. Can you perform the thrombectomizations?
Can you do that thing?
Can you put your father on the phone?
Is there an adult I can speak to?
Right. So before we get into all that, I think, a lot of times when we start talking about pulmonary embolism, there, as far as etiology is concerned, right, a lot of people immediately jump to like prolonged travel, HRT, whatever. Do you want to back us up to the triad?
The Virchow's?
The Virchow's triad?
Yeah, baby.
Yeah.
So most of us probably learned all this in school, but Virchow's triad, just 3 things that can predispose you to clot formation. So venous stasis, they've got some form of venous insufficiency. Venous stasis can be prolonged travel where you're immobilized, and a majority of our venous inflow, right? As we have venous return to the right side of the heart, improving preload and cardiac output is from muscular contraction. So if you're not moving, you're not squeezing those vessels and pumping that blood up towards the heart, blood can pool on top of your valves and make you prone to clot formation. Other forms of venous stasis, whenever I was looking through this, that I think is important to recognize is maybe someone's got baseline cirrhosis or hepatic dysfunction. They're fluid overloaded. They've got some baseline RV failure, maybe some pulmonary hypertension, things that can increase your central venous pressure and impair venous return to the right side of the heart is still a form of venous stasis. Any type of known hypercoagulable states. So those are going to be heritable hypercoagulable states, factor V Leiden, protein C, protein S. antiphospholipid antibody, but then things that people can be taking, right? Oral contraceptives, hormone replacement therapy, are going to be big ones. And then obviously malignancy is a huge risk for being prothrombotic. And then any type of lower extremity injury. So if you've had a recent fracture, and that's obviously going to contribute to immobilization. If you're in a cast, you've got to be on crutches for a certain period of time, all that kind of stuff. So
yeah, don't forget about your paraplegics too.
Yeah. Oh yeah. Good point. Yeah. Very good point.
So yeah, the triads, the Veritas triads, as you said, in this, one of these states has to be present.
Yeah.
And that's the point of the triad is at some point, you know, if you have a patient who has a PE, they have met one of these criteria to be able to do.
And as it is, and I'm saying all these things because we have people listening to this cast across all forms of healthcare and in their education process. So again, I am just saying some of these things that may not be as clinically applicable, but, you know, test question wise, but obviously, I mean, I think it goes without saying, but obviously smoking is a huge risk for endothelial cell dysfunction, clot formation, and all that kind of stuff. So if they're a smoker, obviously that's a big risk for clot formation as well.
Yeah. So just to recap, endothelial injury, venous stasis, or hypercoagulability, one of those three. I did do a breakdown of the risk factors by incidence.
Okay, let's hear it.
I don't think there's anything shocking in here. Recent surgery is number one.
Yeah.
Like 60%. Immobilization or prolonged travel, 60%. In a lot of categorizations, those two will be put together. Cancer, active cancer, history of VTE. You have a strong, it's poorly quantified, but you have a strong recurrence risk. Oral contraception or HRT. So unclear 2 to 3x increase in risk. Everything else, obesity, smoking, trauma, pregnancy, advanced stage, heart failure, CVA with residual paresis, as we mentioned, you know, paraplegics or people with, you know, decreased tone of some kind. IBS, oddly enough, central venous catheters, nephrotic syndrome, and then antiphospholipid, antibody, thrombophilias, factor V Leiden, protein C. And
I love my immunology and the just pathophys of inflammation. But IBS, I mean, if you think about it, no. I mean, seriously, I mean, it makes sense, right? Like inflammatory bowel disease, you have this diffuse inflammatory reaction throughout your bowels, not like Crohn's is, you know, through the whole thing. IBS is generally just isolated to the large bowel, but
obviously. Go on.
Well, I mean, not
Go
IBS, ischemic colitis is. Are we talking about irritable bowel syndrome or?
I don't know what you're talking about. You're talking about all this gobbledygook.
Okay. Well, I'm just saying an inflammatory state is going to.
You're giving me systemic inflammation.
Yeah. All right. Well, it's going to promote clot formation. Moving on.
You don't talk about the intraluminal.
I was, but we'll save that for later.
I got to take your knees out sometime.
Might as well make it early.
So yeah, those are all your kind of predisposing factors, and then the underpinning of it. Do you want to go into classification based off of the anatomy, or
are you talking like location,
segmental, subsegmental?
Yes, lobar, segmental, subsegmental.
And this is just
saddle. Those are pretty much
elucidate what people are telling you, because when people say things like, and obviously people know this, but just to reiterate, when you say things like massive PE, submassive PE, those all mean something very specific.
Right. So, and I was going to pick your brain on this. What I presented is traditionally in the US, we've used massive and submassive.
If you're going to bring up the risk stratification.
Massive to signify that they have hemodynamic instability associated with the clot. Submassive can be elevated cardiac biomarkers, and they have RV strain, but they're not hemodynamically unstable. I like the European Society of Cardiology's classification, and that's what I've been using more here recently, which classifies it into high risk, intermediate risk, which has two separate: intermediate high risk, intermediate low risk, and then low risk.
I do think that's better.
I agree.
Because I ran into a couple situations, I don't remember if I was on nights or what, where we admitted like a bunch of PEs back to back, but I kept kind of struggling with me trying to, what the proper diagnosis is, because I was like, not chalky, but borderline low. Like maybe you're just old and dehydrated, just stuff like that, where I was like, is this massive or submassive? Like and like I'll speak to this one case specifically. This was a very old, like I think greater than 90 individual who had massive clot burden, like massive clot, like scary massive. But just was like, it had some RV strain, but just bored, like on the nose, systolics in the 100s, but like never needed pressors, popped out of it right away. And I was like, you'd feel like this would be massive.
But to your point, I mean, this brings up so many good points that I wanted to elucidate, and I know you're going to, but just, I mean, this is why I think PE is interesting, and I wanted to talk about it because the same amount or same classification of clot is going to present completely differently potentially in an 80-year-old person who has underlying CKD and maybe some diastolic dysfunction and they're malnourished and they've got other medical comorbidities, as opposed to a 35-year-old male who's on some testosterone replacement and just went on a long vacation, right? Like, I mean, the same amount of clot burden could present completely differently in these two individuals. So I think it's very individualized to the patient and their underlying physiology. But then conversely, what I also think is very interesting is like, that's a patient that in external appearance, as you're working through that, right, appears fairly stable. And they are at the time, but especially in a 90-year-old with that clot burden and they're like teetering, like in my mind, I'm like, okay, maybe this is an intermediate high risk, but this patient has a very high risk for sudden and profound clinical deterioration. Whereas maybe if they were even that same risk factor, but they were 35 and they've got this, robust, compensatory response and their sympathetic nervous system can compensate for all this stuff, that they may not tank like that, but like that 90-year-old who's like on a knife's edge, like they could teeter over on that other side and just kind of go downhill really fast.
Just die
Yeah,
suddenly.
exactly.
Are you like me when I'm on a road trip? If I'm getting gas, I'm doing squats.
Oh, like I'm full dad mode where you're like doing deep squats at the pump. I'm like stretching, even sometimes this is just the cons of working in medicine and doing what we do, right? But you're like sitting in the car and I'll even be like, gonna start
squeeze.
Yep, start tapping, do some calf raises and
tighten the thighs.
Give a little.
Well, especially I freak out a little bit when I'm in an airplane. Like I just came back from Austin, and like if I book my own flight, like I'm getting exit row, paying for the upgrade, right? Because I'm a tall dude. I'm a big guy and a tall guy, right?
Yeah.
So, but I didn't pay for these tickets. And the first I was like, oh, it'll be fine. I won't upgrade. And I'm like locked in a stationary position because like my knees are touching the seat. I have nowhere to go. Yeah. So I just keep like.
You are, people can see you now on camera. I mean, this isn't any type of, dig at your size.
Here we go.
No, you are no. You are a robust man, right? You're tall, you're big.
Broad baby, broad back,
big old guy, mountain of a man. What's it like for you? Can you get into a airplane bathroom? I mean, I'm just curious now that we're talking.
Yes, I can get into an airplane bathroom.
I have a hard time navigating inside these things. Like,
what kind of question is that? You think there's bathrooms in this world I can't use? Because I'm the mountain. Dude, it is tight. It's real tight in there.
Navigating.
No, it's a rough situation.
Be a hard thing.
I was laughing to myself when I was on the plane. There was on one of the legs. There was a gentleman sitting next to me, and he just crossed his legs, and I was like, "Must be nice, short man." I'm not short shaming anybody.
Look at all that room you've got.
Yeah, look at that. You're just not struggling at all.
Yeah.
And I'm fighting for my life over here.
Yeah. Well, and go back to medicine. One other point that I wanted to make is, it's not so much the size of the clot to me that is the more disconcerting factor, because I know that you've seen it. So when we're talking about a saddle PE, right? Like that's the key term and the worrisome finding, and everyone has a little butt pucker moment because the clot is saddling the bifurcation of the left and right pulmonary artery, right? And so it's causing a little bit of occlusion to both or even more. But those are so if you're blocking obviously both sides of the circulation, you can result in, essentially no flow to your pulmonary vasculature. But I've seen it, you've seen it, where someone has a saddle PE and maybe they even fall into the intermediate low risk category, which I'll outline all those categories. But so conversely, you can have someone who's doesn't have the compensatory physiology, who's 90 with all these other medical comorbidities, who maybe has more segmental or subsegmental PEs, but they have a large clot burden. Think about that. it's all about the total cross-sectional area of pulmonary vasculature that you're occluding, which is increasing your pulmonary vascular resistance and the afterload that the RV has to pump against. So I think that just getting your head wrapped around like the size of the clot isn't the whole picture, and it's what's the underlying compensatory response of the patient, and then what's the overall clot burden.
Yeah. And just for clarification purposes, because I know we've mentioned this a couple of times, you're in this classification spectrum, low risk is normotension, no RV dysfunction, no cardiac injury.
Right.
Right.
In cardiac injury, we're talking about trope and BMP.
Yeah, you're looking for a stressed out heart. Submassive PE, normotensive with evidence of right ventricular dysfunction and or cardiac injury. And then your massive PE is sustained hypotension, so you're essentially obstructive shock, cardiac arrest, high mortality right off the jump, like 25 to 30% right away. And that is like right away, that's your strong considered for systemic thrombolysis or catheter-directed therapy.
And what I found in that massive PE or in the high-risk PE is a lot of these patients, when they collapse, I mean, they can die. If they die, it's going to be within probably like 2 hours of hospital presentation.
If he dies, he dies.
So it can happen pretty precipitously.
Just going to ignore my Rocky reference.
Was that Rocky?
Yeah.
If he dies, he dies.
That's what's his name? Drago.
I'd be a little bit better off if these were Rambo references than Rocky.
Okay. Anyway. Okay. So we talked about classifications. We've talked about etiology. Do you want to get into kind of the nuts and bolts? I mean, there's the obvious component of you're not going to oxygenate well because you can't get blood where it needs to go, right?
Yeah.
So that's problem one. But do you want to get into maybe the RV dysfunction, RV death spiral a little bit? See how I set you up for that?
Yeah, I feel like you said it a little bit begrudgingly, but I feel like maybe I'm painting that picture in my mind.
I'm in agreement with you because obviously just coming back from the Impella conference, we did a lot of discussions there, and I was honestly really happy with a lot of the commentary around not just focusing on the left ventricle and the cardiogenic shock, but preservation of the right ventricle whenever you need hemodynamic support or you're in a shock state. So I do think it's really important.
I mean, what's the most common side of right-hearted fart? Right.
Were any of those English words?
Oh, I think I just said fart. Right fart. Right-sided heart failure is left-sided heart failure, right? It's going to take you time to recover from that.
Dude, that was brutal.
Reel it in. And we're back. I would say we could cut that out, but he won't. So
no, this is what the people come for.
This is what the people want.
Yeah.
But obviously we know that one of the most important parts to cardiac output, left ventricular ejection fraction, all that kind of stuff is going to be preload. And the left ventricular preload is going to be dependent on the RV systolic function, right? So if your RV is failing, it's going to pretty quickly precipitate RV failure. And again, to my point of what the clot burden is, the whole idea of how the RV is going to fail here is that you're increasing the pulmonary vascular resistance. Now you're increasing the afterload that the RV has to pump against, but the RV and the pulmonary circulation is a very low pressure system. We want a lower flow rate as we go through the pulmonary capillaries so that we can diffuse oxygen and get rid of carbon dioxide. And so that happens very slowly, so we have time for that exchange to occur. RV pressures, low, right? Atrial pressure, what like 8 to 12? I don't know all the Swan pressures off the top of my head.
3 lectures and you got nothing on
me. Well, I don't lecture on all the right-sided heart pressures from a Swan, but
just say this isn't a hemodynamics lecture. Look it up.
Yeah, look it up. But just obviously starkly compare the stark comparison of, let's say, right-sided pressure of 20 to 30 millimeters of mercury, whereas you have a systolic pressure of 120 millimeters of mercury.
You're talking about RVSP.
Mean right-sided heart pressure.
Okay.
Yeah. But as you increase that afterload, the right heart's got to pump harder, but the right heart doesn't pump against a high systemic vascular resistance, high pulmonary vascular resistance. It doesn't have that myocardium, that strength to pump against it. So very quickly the RV can become strained, over distended, and lose systolic function. And then the whole spiral of things occurs where,
Say it.
I'm getting there. This is where people
say
are
RV death spiral.
The RV death spiral
There it
is if the RV is getting overdistended and we're having reduced RV systolic function, then you're reducing left ventricular preload. So then your cardiac output can start to fall. So what does the body do to compensate for a reduced cardiac output? It tries to increase stroke volume, and it increases heart rate. And as we increase heart rate, we reduce the time in diastole, and we reduce coronary filling time because our coronaries fill during diastole. So now you have a right-sided myocardium that's getting stretched and distended. So it's probably not getting very good blood flow to the myocardium anyways, because you're compressing those endomyocardial vessels. And then you're also reducing coronary perfusion because you're having reduced time in diastole. And so now you can make your RV that's already struggling against the afterload ischemic, right? And so that's why you're going to see elevated troponin. You're going to see BNP because of the stretch on the right ventricle. And then obviously, unless you fix this problem, it's just going to keep getting worse. That resistance can keep getting worse. That fluid can keep backing up into the systemic circulation. The heart keeps trying to compensate sympathetically with that heart rate. You get more ischemia. So, truthfully, with those elevations in troponin, I mean, it wouldn't be abnormal to see. You could truly get like a true in-STEMI, right, without any type of coronary obstruction, just because of the oxygen, and then take into account that the blood that you're delivering to the coronaries isn't oxygenated well because of this PE, right? So, all of those things just result in this kind of continual death spiral.
Non-ischemic, non-traumatic myocardial injury.
Yeah, that one.
I love saying that one.
So I think that's what's so interesting about it and important to recognize that that's why things can kind of go down so quickly. And that's why these patients are such a high-risk intubation procedure. And we've kind of outlined high-risk intubations and why that's going to happen. But this patient is relying on this really high sympathetic tone to try and compensate for everything that's going on. And as soon as we give them these sympatholytic medications that we're giving to intubate them, you can lose that systemic vascular resistance.
All that sport's gone.
You can lose that compensatory tachycardia. You're switching to positive pressure ventilation. All these things that we've outlined and have been outlined in the critical care literature and on other podcasts very well, but can just quickly result in circulatory collapse. And so intubating these patients may be necessary, but it is not one that you want to do. No, it's not ideal.
This does fall into the category of patients you really don't want to intubate,
right?
Unless you absolutely have to. Which is why, and I say this as a form of reassurance as almost a response to the common question of, well, why haven't they done X or Y? I assure you that whenever we've gotten the call, if it's appropriate, we've already spoken IR, which is more often than not. We've already, not even us, the emergency physician's already sent off an echo. He's already ordered a lower extremity ultrasound looking for DVTs. He's already maybe called IR, or we're going to call IR right on the back of them before they even hit the unit. Like, they're pretty well worked up.
The whole, especially in a PE, right? Because this is something that is annoying to diagnose, right? Because it literally always has to be on your differential. However, how often are you actually diagnosing PE? I mean, don't get me wrong, PE is common. We're diagnosing PE every single day in the ER, right? But someone comes in with dyspnea, maybe a little bit of chest pain, some pleuritic discomfort. I mean, and it's a critical care podcast. We don't need to cover all that stuff, but there's criteria to try and rule out a PE, but it's much harder to rule out a PE than it is to rule in a PE, if that makes sense.
Well, and I'll piggyback on that because it's one of my probably, I don't want to say frustrations because I think that's a wrong characterization of it, but you do this too, but we both service virtual care all the time, right? Yeah. So we are overseeing a lot of times these rapid responses, and like you said, PE is always on the differential. But the amount of time sometimes that people will jump straight to PE, and I'm like, PE, like if you're talking about say like Wells criteria or whatever, right? Like,
PERT and Wells is what I was getting at.
Is that light killing?
Well, it's like it's coming just through those little bitty holes, and it's like right in my right eyeball. So I'm like trying to adjust myself, but then I'm like, you can see the...
Yeah. This is a part of the learning experience when videoing, right? But the amount of times I've heard, and I won't fault anyone for saying it, but like, oh, this patient needs to go for a CTA right now. I'm like,
It is why so many CTAs are done, though, right? Because you don't want to miss a PE.
No, you don't.
And it's really hard to, you can always convince yourself to get a CTA. It's hard to talk yourself out of getting a CTA, right? That's a good way to put it. But so, I get it. I'm not faulting anybody. We're on the other side of things. So I'll just stare into it and just
I'm like,
take it.
With the way the sun's moving. If you just keep letting it go, it'll be out of your eyes. You're in a pretty good position now.
Yeah.
So, and that's the hard thing. What is, I'm trying to think.
Like wells, I think it's if you have a wells greater than
I want to get
6 or 4.
Exactly what it is.
Because I presented this, I can tell you some of the criteria, but let me just say that it is not hard to get over the number of positive the numbers that you need on a wells screening to get a positive signal.
Let's look at this in the frame of a rapid response really quick. So I just pulled it up. So we can say, yeah. So let me pull this up real quick. I'll just run through it really fast. Wells criteria. These are all the individual criteria. Clinical signs and symptoms of a DVT to PE is number 1 diagnosis or equally likely. Heart rate is greater than 100. Immobilization at least 3 days or surgery in the past 4 weeks. Previous objectively diagnosed PE or DVT, hemoptysis, malignancy with treatment. So we'll go heart rate greater than 100 and then immobilization at least 3 days or surgery, right? So that puts us at 16.2%. So scores less than 4 are unlikely. So we're close already, right? So let's say, what's another one? Let's go hemoptysis because we have a fair amount of hemoptysis. Boom. Like you've now met criteria.
Yeah.
Right? Now it's still low. It's still low risk.
But it's saying that you can't exclude it without further diagnostic testing.
Right. Yeah.
Right. And so what's going to mostly happen? They're going to get a CTA because you could check a D-dimer. I hate D-dimers. Should we go off on D-dimers?
I would just say this. D-dimer is so nonspecific.
Yeah.
Like all your patients who are critically ill are probably going to have an elevated D-dimer of some kind.
All it means is that you have elevated evidence of fibrin split products. So they've had a clot somewhere and they're breaking up the clot. Cool. Yeah, that doesn't mean that it's a PE. It means that anybody who has sepsis or is critically ill is going to be probably having a little bit of thrombosis.
Right.
If anything, maybe it means that their body's trying to do what it should be doing, which is breaking down the clots that we're breaking, right? So anyways, so that's a patient that's being presented to us that's already been diagnosed through the ED and then is coming to the ICU, right?
Yeah.
Another thing I wanted to kind of outline because we love POCUS.
Do we?
You love it. You know you do.
I've been doing a lot more POCUS.
You have. You're getting better. Don't let him lie to you, folks. He just told me the other day about he just put the probe on the chest and got a perfect parasternal long.
Got it right off the jump, baby.
And he was just like, oh yeah.
And then all the people in the room are like, are you seeing this? And I'm like, I don't know what I'm seeing. And I'm like, I see it.
But let's say to your point that someone's got has a rapid on the floor or they have new hypoxemia in the ICU, and most patients in the ICU are going to be tachycardic. What's the most common EKG finding in PE? Sinus tachycardia. For all you school people out there, it's sinus tach. It's not the S1, Q3, T3.
No.
That's just a sign of right-sided dysfunction or right-sided heart failure. But I got pimped on that question, so trying to help you out there. What's the most common EKG finding in PE? It's sinus tach.
I feel like it almost goes without saying.
Yeah.
It's like that's going to be the case.
So you've got someone who's sinus tach, they're hypoxemic. You've got to have PE on your differential, right? Yeah. Say they've been in the hospital, though. They've certainly been on some form of VTE prophylaxis, right? Not that they can't still form a clot.
Maybe.
But they should be on some form of VTE prophylaxis. But what am I going to do? I would say, what are you going to do? I think you would do the same thing. First and foremost, I'm going to go to the bedside and I'm going to perform a ultrasound exam. If you follow the blue protocol on the lung ultrasound, if you have lung sliding present on both sides and you have a predominant A profile, which just signifies that you don't have interstitial or alveolar edema or infiltrate, things like that. It's very, I love it and I wish we could implement this more. I try and work through it regularly, sliding A profile, meaning you're not finding consolidation or signs of interstitial lung disease or alveolar edema, stuff like that. Boom. Next thing it says to do is a lower extremity VTE exam. If you find a clot, it's PE until proven otherwise.
Right.
So I'm also going to, I may not even jump directly to the lung ultrasound. I'm first going to look at the heart, especially if they're having any hemodynamic instability, right?
Right. Yeah.
But if you've got a newly dilated right ventricle, if you look in a parasternal short axis view, normally the right ventricle should be a little bit more like crescent shaped because of the low pressure system. It doesn't have as much volume. The interventricular septum from the left ventricle is kind of, more into the right sided space. So that's how it should normally look. LV should look nice and round and concentric, and the RV is kind of crescent shaped. But if that RV is, they call it a D sign, where it's kind of flattening that interventricular septum big and dilated.
Yeah.
I mean, that means that you've got signs of increased right sided heart pressures. The hard part is delineating whether that's acute or chronic, right? Because people can have pulmonary hypertension and other issues that cause their RV to be chronically dilated, but you should see that their myocardium is a little bit more hypertrophied if it's a chronic process. You can measure it. I don't remember what the measurements are to do that, but either way, my point being, if someone's acutely decompensating and you have PE on your differential and I see a dilated right ventricle or reduced RV systolic function, then I'm going to do a lower extremity ultrasound exam. If there's a clot there, it's PE until proven otherwise. And in the setting of hemodynamic instability, I would say that that's enough clinical evidence for me to go ahead and push thrombolytics. If they're not, in a peri-arrest period, then you can always, of course, order a formal echo, see if they see a McConnell's or something like that. And if you deem them stable enough, maybe send them for a CTA. But, there are ways for us to delineate a pretty high positive predictive value of possible PE, at least to the point where we can justify pushing thrombolytics in someone who's acutely decompensating in front of you.
Yeah. So the point being, get good at focus, baby.
Yeah.
Baby. Yeah.
Get on my train.
Yeah, we talked about, obviously, from the perspective of like EIT, RRT, things like that. We've talked about the perspective from starting in the emergency department. When we talk about thrombectomy or no thrombectomy, almost exclusively that is led up.
Embolectomy.
Yeah, thrombosis. What'd you say?
Thrombectomize.
If the IR doctor decides I want to perform a thrombectomization. But a lot of times that's not our decision. And just like there are some driving factors. And the only one I really want to kind of get to is the fact that similar to brains, right, the more distal these clots are, the higher risk, your risk to benefit ratio begins to drop. So it's like you might have a patient who's somewhat hypoxemic, but just has kind of multiple distal clots. But is this something you just need to write out? That's
a great point. Is it? I would assume too. I'm not an interventionalist. The more peripheral you get, the more risk the procedure carries.
Yeah. Well, the smaller,
farther you have to travel, the smaller you're going through, the more risk of causing damage or rupture. But
applies to essentially any endovascular situation for the most part.
So that's a great point. I mean, even let's say that someone is that patient that we talked about who maybe has a high clot burden, but it's a lot of more peripheral clots. That may be someone that even though they fall into this high risk or intermediate high risk group, that they're like, they're not really a candidate for embolectomy. One, because of all the clots that are around, and two, the location of the clot. So again, you're going to be consulting, like you said, lots of potentially different people in this, but ultimately it's going to be your interventionalist call on whether they feel that the patient's a candidate or not.
Right. So they make that call. Obviously, we are kind of, I want to say, it's us, the emergency department, a lot of times are kind of colluding together to decide whether somebody needs systemic TPA now. And a lot of times, I don't want to say it's unclear, but a lot of times it's pretty definitive, like when they do or when they do not. Now, that can change across the spectrum of care, right? You could admit somebody who's like borderline unstable that then becomes unstable, at which point you change your mind. Like that case that I had referenced, even though they were doing so well, relatively well for the size of the clot burden, we already stated with any sign of deterioration, you're going to have to do systemic TPA because the clot burden is so significant, right? Obviously, if you're not doing systemic TPA, you're heparinizing these patients. And then you want to talk a little bit about windows for transition to oral coverage or as you get closer to discharge. Yeah,
I mean, for me, I think it just depends on what is planning to be done or not be done by interventional, right? Because if you're not going to thrombolyse this patient, and then the interventionalist comes back and they're like, we don't think they need embolization, they can just be treated with anticoagulation, then to me, unless there's, other multi-system organ dysfunction that's going on, renal dysfunction, all these things are going to come into play, right? But as far as just treating the clot goes, if there's no indication for going for a procedure and we aren't going to push TPA, then I think that you're fine to start transitioning them to oral anticoagulants, even if they remain in the ICU and maybe they're on a little bit of pressure support. Sooner than later. I don't think that we're gaining any benefit. Anticoagulation is anticoagulation. Putting them on a DOAC is not in any way, in my mind, inferior to having them on a heparin drip, and I can go off on that. But pinning the patient's physiology and volume of distribution and yada da da da, chasing PTTs around the clock, like we may be actually doing our patient a disservice, or we could be getting them in the therapeutic range of anticoagulation faster and better by switching them to oral anticoagulation sooner.
Right.
So in my mind, it's just really what's going to happen in the immediate phase of getting them to the ICU as far as procedural or not, and then from there, I think you're fine to start transitioning pretty quickly.
Yeah.
Within 24 to 48 hours.
Yeah. And at what point are you okay with these patients leaving the ICU?
Again, if there's no indication for procedure, they've been on anticoagulation, we know that they're in a therapeutic range for their anticoagulation, and they're hemodynamically stable, then I'm fine with them moving out. Obviously, they're going to stay in the ICU if they remain hemodynamically unstable and they need to be on a little bit of vasopressor. But generally, right, these patients should improve fairly quickly. And, I think this goes without saying, but remember, the only thing that we're giving to break up a clot is the thrombolytics, right? We're lysing the thrombus or the embolus. But by putting them on anticoagulation, we're just preventing further propagation of clot formation. So
I think that's a good point. You're not breaking anything up. You're just stopping it from getting worse.
But the body will resorb, what clot you have. I mean, we just talked about that's what a D-dimer shows, is your body has ways to create and also break down clots, like you're keeping it in this kind of constant equilibrium. So over time, it will improve. We just want to prevent further clot formation. And we discussed, you mentioned that you would get this test if I'm evaluating someone. We talked about performing one at the bedside, but everyone who comes in with a PE, we're going to get a lower extremity ultrasound exam on, either done by yourself or a formal study. And then, pinning the residual clot burden, if they have a lot of residual clot burden, then I still may be talking with the interventionalist, because if they have a huge, extending VTE from like their iliofemoral all the way down to their popliteal or something, like they can embolize, or that would be a thrombectomy, right? They could thrombectomize that while they're in there too. So pending what other findings they find, there could be potential role for intervention there. Or if they have this huge clot burden, then it may be like, why is it such a big clot? Maybe we should talk to a vascular specialist, see if they need a hypercoag workup or something like that.
Yeah. All good points.
Thanks.
You're very astute.
I got nothing.
All right. So as we get close to the end, is there any other points? Oh, I said I was going to ask you, then I just want to tell you something. One thing I do want to emphasize for both nursing and providers is set an appropriate expectation with these individuals. The amount of times I have to go to the emergency department and somebody goes, is this going to make all this stop, like meaning shortness of breath and things like that? I have to say, I'm not sure.
Yeah.
Like, hopefully, some people feel better immediately. Some people, it takes a while.
Yeah.
And I like to emphasize with setting the expectation that your recovery can be quite prolonged after this, meaning that, you might get off supplemental oxygen within a day or right afterwards, but the chances of you having exertional dyspnea and kind of vacillating levels of fatigue associated with it's going to persist for a while.
That is a fantastic point, because unless they have that clot sucked out of there, as we just alluded to, it ain't going anywhere. No. And it's going to take time for the body to rid yourself of this. We're going to prevent you from developing more of these clots, but it's going to take time to get rid of these. So, that's an excellent point. You may improve to the point where you can get out of here, but the chances that you're going to have some residual symptoms for, weeks to months, probably pretty high.
It's high.
That's an excellent point.
And it's always great when they come back from a procedure and they've had everything, sucked out and they're like, I feel great. And it's like, cool, but temper your expectation, because when you're up and walking around here in a minute, you might not.
Yeah.
Right.
I do think this is a cool illustration of a disease processes that we see in the ICU. Let's be honest, a lot of patients that we treat, infections take a long time to recover. Given their age and comorbidities, the patient takes a long time to recover. Lots of people don't recover. Yeah. But this is a very cool disease in the sense of it can span such a broad width of patient demographics, and depending on what's done with them, they can improve very quickly and feel a whole heck of a lot better. This is where being an interventionalist would be very gratifying, right? They do these thrombectomies and strokes and things like that, and embolectomies and PEs, and they get to immediately improve somebody's quality of life, and obviously prevent them from potentially dying. Right. But yeah, it can make such a huge difference in such a short amount of time.
Yeah, and it's a little bit more. Even though we've just talked about how it's not super predictable, it's a little bit more predictable than say something like mechanical thrombectomy and stroke and TPA. It's amazing when they do it, and all of a sudden those deficits start to disappear, and they're like, they're coming back to normal. But it's like, it's one of those things where you can't necessarily predict it that well.
I did have one pearl that I didn't mention earlier that I wanted to throw in there. So generally, right, if someone is hypotensive in the ICU, one of our first and foremost first things to try is giving them some fluid, right? Mm-hmm. And these are patients that I would say that you need to be cautious and wary of your fluid administration.
Very judicious.
Very judicious, because the whole pathophysiology that I outlined earlier, the heart is already struggling against the increased pulmonary vascular resistance. It's reducing the LV preload. If we increase the preload to the RV that's already struggling and already distended and already can't handle that pressure, there is a Frank Starling curve for the RV too, right? But once you get past that point and we just keep over distending, you're going to worsen that compression and probably reduced myocardial oxygen supply, and could potentially worsen and propagate the problem as far as just their clinical deterioration. So unless they have like clear signs of potential hypovolemia on top of everything, like this is a patient where I'm going to be leaning more towards initiating vasopressors if they're hemodynamically stable, considering thrombolytics or talking to our interventionalists, as opposed to giving fluids. All right.
Well, as our second camera dies for the second time,
I
think I'll mention one more thing is that pulmonary infarction can also be a sequela. What do you do about it?
Not a whole lot you can do.
Not a whole lot about it.
This is the classic test question where someone presents with shortness of breath, cough, pleuritic discomfort, and some hemoptysis. Right. You can see it's called a Hampton's hump on chest X-ray. I don't think anyone's ever seen this little wedge at a pleural-based wedge and been like, oh, PE, everybody. But what that is to signify is the area distal to the occlusion of the pulmonary artery has had lack of blood flow for long enough now that the tissue is infarcted, and that's what it is. So,
and I'll also say one more point is that, historically in school you learn about hemoptysis. Hemoptysis now is a late sign.
It's a rare presentation, and like you said, it's a late sign because, again, what we just outlined, that means that tissue's been malperfused for long enough that it's necrosed and ischemic and everything. So it's been going on longer than it should have been.
Whoops. And there's a lot of other little nuanced things in there that, like a patient who develops hemoptysis with, anticoagulation or whatever. And there's really not a lot to do. There's all these little things that pop up that'll, people have to say, well, what if this? Then the answer is like, there's nothing really to do. You just kind of support them.
I mean, we didn't outline them, but there's risk to starting anticoagulation, right? I mean, there's risk to thrombolytics. We didn't list the absolute contraindications to administering thrombolytics, but those are there. If they have a known intracranial neoplasm, if they've had a stroke within the last 3 months, I think, if they've had recent surgery, those types. So there's absolute there's absolute contraindications to thrombolytics as well. So, I mean, everything is obviously a risk versus reward, but especially on the anticoagulation realm of things, I think in my mind, anticoagulation is a must. And it's more so of if your patient is at risk for anticoagulation, maybe you can go lower dose, or it's a very intensive conversation with your patient outlining the risk that they're at with the anticoagulation and trying to mitigate, falls and these other things that could result in some of those sequelae. But, obviously they need to be on it. Last thing, I guess, is duration. So generally it's going to be 3 to 6 months of anticoagulation. Yeah. Whether it's provoked, unprovoked, you can go through all those nuances on your own. If there's any question about it, talk to your vascular specialist, and they can guide you on duration of anticoagulation.
Yeah, and I should probably just, since the only one's running, there are also certain indications of which, especially patients who have recurrent severe presentations, and lifelong coagulation might be indicated. We've had a couple of those cases.
Oh man, I keep thinking of things. But last thing, hey Ron, how do you feel about giving somebody's got a creatinine of 1.75? I think they might have a PE. I'm going to send them for a VQ scan.
Okay. Do whatever you want.
I expected your face to just well with anger.
You can't see it. You can't see it on my face right now.
So,
I like how you looked at the camera that's dead, by the way.
I'm just saying, if you suspect PE and they have renal dysfunction, get the CTA. Yeah. We can fix an AKI. Yeah. Right. But missing
most of the time.
Yeah. But fixing a PE is not something we want to.
One will hurt you. One will kill you.
Yeah. So that's my last little soapbox.
Yeah. And like I said, there's a lot of little nuanced things in there, but that's the sum of the parts. Obviously, if you've made it this far, you know that one of the cameras has died. So now you're just with me. So I'm going to thank you for tuning into the Full Code Podcast. You can just come over here and join me in the frame if you want. We can snuggle up together. Thank you for joining us at the Full Code Podcast. We appreciate all the support. Lots of things in the works. Obviously, we've mentioned there is the ventilator conference upcoming. So come out and see us. We'll be presenting. Our topic is, did you even read the title I put in there?
Yeah, what you don't know, or something along those lines.
Yeah. So
I know what it entails. I just didn't know your nice little play on words there. Do no harm. KNOW.
Ruins it when you have to say it like that.
Yeah. Well, sorry.
What was it? The subtext? Understanding the cost of saving a life.
Yeah.
Yeah. So one of the topics we'll be talking about is in these patients who are critically ill or rapidly deteriorating, you're obviously making decisions to try and save their life, but you have to understand what the ramifications of those things are. But yeah, that'll be coming up in October. Yeah. Other than that, we have a couple interviews lined up for this month, and we're hoping, as we kind of keep treading deeper into the audiovisual space, to keep formulating content and bringing stuff out. And I've gotten some good suggestions about potential topics that we'll go over coming up. But yeah, head over. Obviously, if you're watching the video, you're probably on the YouTube. Head on over to the YouTube, like, subscribe, follow. That really does help. Check us out on Spotify, Apple Podcasts. I actually figured out that the majority of our listens actually comes from Apple Podcasts.
You were hating on Apple Podcasts so much. You're like, oh, I'm a Spotify guy. I'm like, I listen to all my podcasts on Apple. And when you were sending me all the streams that we'd gotten, and then, but wasn't it a pleasant surprise though, since we didn't know, and then we're like, oh, there's this whole other platform that we'd been missing the numbers on. So yeah, we have more listeners out there than we thought. So that's good.
So but yeah, we appreciate you guys tuning in, all the support, all the feedback. It helps us, really does help us kind of formulate and figure out how to best help in the space, because that's the goal, is you're trying to help clinicians, nurses, everybody.
1,000%. And sometimes we feel like we're hitting, bread and butter, but normal stuff, which you want to, what you see regularly is what you see regularly. That's what we want to make sure that we understand well. But at the same time, it's not like we're the only medicine podcast out there that's covered some of these topics. So if you have other suggestions, let us know. We want to know what you guys want to hear. But we also want to keep it high yield that's going to apply to a broad breadth of people who are taking care of people in the critical space. So,
right. Yeah. So that's it. Thanks for tuning in.
All right. Later.